Welcome back, OSLP family. Welcome. You're listening to our Sleep Life podcast, and this is Kelly.
This is Mel.
And we did it, you guys.
We did it.
We nailed down a plastic surgeon. We have him with us. And we are going to go over all of those burning questions that I know we have and you guys have. We are just...
For those that don't know, we've messaged so many plastic surgeons.
Yes.
That's why we're so excited.
Yes. And this doctor is very special because he specializes. He loves doing weight loss surgery patients.
Yes.
So
that's what's so cool about this
We are
one.
so excited to have Dr. Beidas on the podcast. Welcome.
Welcome.
Thank you so much. It's an honor being here.
Thank you. I mean, it's an honor for us because we've seen before and afters. We've seen your posts. We're super excited to see more before and afters from you because this is just, it's a scary thing for somebody to go under the knife for plastic surgery.
Yeah, of course. It's a big decision. And obviously for everyone, we always say, it's a very personal decision. And a lot of patients choose not to have plastic surgery. And at the end of the day, you got to do what's right for you. So
Exactly. So tell us a little bit about your background. Tell us how you got into weight loss surgery, plastics, all of that.
Yeah, sure. So I am based in Orlando. I work for one of the big hospitals here called Orlando Health. And I've been here for about 3 years. And I did 7 years of training before that. So 10 years.
That's a lot of training.
That's a lot.
I love it.
It's a lot of surgeries.
Yes.
And what's unique is I did a 1-year fellowship up at Pittsburgh, at the University of Pittsburgh, that was dedicated to weight loss patients. And so I trained with a lot of the people who invented and mastered techniques that are special for weight loss patients.
It's so cool.
It was pretty cool. So Dr. Peter Rubin was my mentor, and Dr. Jeffrey Gusinoff. They're two kind of big names in the weight loss surgery population, or rather plastic surgery after weight loss population.
Oh, cool.
Yeah, so they're great guys. They write textbooks. They travel all over the world and lecture on this stuff. So I was very fortunate to have trained with them.
Yeah.
And so I did, like I said, that 1 year, we operated mostly on weight loss patients. And as a lot of you know, the skin is not really the same. Just like when a woman is pregnant, you stretch the skin, just like when you are kind of overweight, you're going to stretch the skin as you gain weight. And then as you lose weight, you see a lot of that elasticity stay. Unfortunately, it doesn't really go away. So the skin's really loose and weak. So a lot of the techniques that we use for weight loss patients are not the same as the techniques that we would use on the average person who's not been, heavier and lost a lot of weight. So like breast lifts are not the same in someone who's a weight loss patient versus someone who is not. Or is and is not.
Yes.
I mean, that's super interesting because I don't think a lot of us knew that because I did not know that at all.
I didn't either.
It makes way more sense, but absolutely had no idea because I was kind of curious who would do those people that the 600-pound the show.
Yeah.
I was ooh, I wonder who would do that. But yeah, that would be hard. You wouldn't know where to start if you never were trained. That would be nuts.
Yeah,
and I know that.
Well, and it's we always talk about how you've got a lot of excess skin on your breasts, especially right at the top. And so it makes sense that you would need somebody that knows what they're doing versus just going into just a normal plastic surgeon. And, it's just different techniques.
Yeah.
Yeah. So a lot of, I do about 2 to 3 weight loss patients a week, whereas probably the average person is doing 2 to 3 a month.
Wow.
So it's really important to do research on who's doing your plastic surgery. It's even more important to make sure you are seeing a plastic surgeon because I can't tell you how many patients I've had come in my office who have had surgery elsewhere. And it can be in town, it can be out of town. And then you look up the surgeon's name and they're, what's called a cosmetic surgeon, which is very different from a plastic surgeon.
Oh.
I don't know if you guys covered that in a previous episode.
No, we have not.
Could you kind of go over
what
that?
What is the difference? I'm curious.
Ooh, don't let me get started, but I'll give you a short and dirty.
Okay.
So plastic surgery is typically 6 years. It used to be 5. Now it's 6 of training in plastic surgery. Plastic surgeons are typically members of the American Society of Plastic Surgeons, but are at least board certified by the American Board of Plastic Surgery. Okay. The other route is to do 5 years of general or ENT, and then do 3 years additional in plastic surgery.
Wow.
So it's a long way. It's at least, 5 now, it's 6 years. Mm-hmm. There's another board that kind of crept up called the American Board of Cosmetic Surgery. And though that board will let you do you can have any training. So a lot of these people are gynecologists, general surgeons, who will do like a weekend or like a 3-month or 6-month fellowship in cosmetic surgery, and then open up shop and start doing tummy tucks and breast augmentations. Whoa. Right. So it's very, very different training backgrounds.
That is scary.
That is nuts.
Yes.
So that's why you see such a huge difference sometimes.
Yes.
Of like, I went here, there's a huge problem, but you go over here, then they're amazing.
Yes.
One's board certified. Wow.
Yeah. So the important thing is to check the Plastic Surgery Society website is plasticsurgery.org.
Okay.
And if you go there, there's a link at the top that says find a surgeon. And most plastic surgeons will be members of that society, which is the American Society of Plastic Surgeons.
Wow.
Okay. We will definitely have that in the show notes, guys.
Yes. Yeah. Because that is super important, because like we said, it's a big decision. Anytime you're having a surgery or going under, and this is altering your body. So you want to make sure that it's going to look good when you're done, and you're spending a lot of money to do this, because it's not cheap to get plastic surgery, but you're also going to live with this body for the rest of your life.
Yeah.
So
I want someone that knows what they're doing.
Correct.
Yes.
Wow.
And there's a lot of things. The first thing is I always tell patients, you're not going to hurt my feelings if you go have surgery with someone else, but don't go to the guy who's charging you $3,000 and is not a plastic surgeon. So if the price is too good to be true, it is too good to be true.
Okay.
And the other thing I tell patients is it's really hard to fix a complication or a problem, like a bad result. It's, pay more, get it done right the first time, because it's a lot harder to fix someone else's work if it's gone bad.
Oh, that's a good tip. That is a really good tip.
I had no idea.
Yes. So can you tell us what the process is once you've had weight loss surgery, you've lost all of your weight, and you've decided, hey, I think I want to have plastic surgery? What's the next steps to that?
Great question. So typically we like patients to have a stable weight for at least 3 months, ideally 6, even more is better, of course. So, we want to know that you're maintaining that weight, right? You're not like in this slope of I'm still losing weight, or you're not yo-yo dieting, going up and down. So you want to have a stable weight for, I would say the very minimum is 3 months, and you're not on like phentermine or any kind of fad diet to get to that weight and maintaining that weight. So you're having a lifestyle that you can maintain, and you're doing that for at least 3 months, and you've kept your weight at that, within, let's say, 5 or 10 pounds.
Okay.
So that's number one. I would say you really don't want to start considering plastic surgery until you've hit that point.
Okay.
And so typically that will happen about a year to 18 months after bariatric surgery.
Okay.
If you're following your bariatric surgeon's recommendations.
Okay.
You're eating your protein, you're doing your diet, your exercise, etc. Otherwise, there's really no other requirements. Most of us won't operate on smokers, myself included.
Okay.
So if you come in and see me and you're smoking, I'm going to give you a nicotine script and tell you to call my office to schedule after you send us a negative test.
Oh, wow. What's the reasoning behind
that? So when you smoke, the nicotine nicotine along with a couple of other 100 metabolites in cigarettes. So your vessels, just for illustrative purposes, let's say this is the normal diameter of your vessel. When you smoke and that nicotine enters your system, your vessels get like this small. And so the blood supply and the nutrients just aren't getting to those tissues. And because there's a lot of manipulation, tissue manipulation being done in plastic surgery, we're rearranging things, we're tightening things. And there's a lot of tension on the incisions that we make. And so smoking is just going to give you a much higher risk of having a wound opening or an infection after surgery.
Oh, wow. Wow.
Okay. What about blood clots?
So blood clots like in your calves, you mean? Like the ones that can go to your lung?
Yeah.
Right. So DVT, the blood clots we worry about. That's certainly a risk factor. So I talk to that about that to all my patients.
Okay.
The best thing to do, which is what I tell all my patients and make all my patients do, is to walk 3 times a day, beginning the day after surgery.
Okay.
For most patients, I'll also give a blood thinner before they go to sleep.
Okay.
So, surgery is a risk factor for blood clots. And then being immobile is a risk factor for blood clots. That's why, like, when you take a long trip in a car or on a flight, you're at risk for it.
Okay.
And so now you add 2 things together. So that's 2 risk factors. And then a lot of these surgeries are long if we're doing multiple stages. And so that's another risk factor. And then, there's a scale, and age is another risk factor if you're over 41. And so you add all those together, and typically I end up giving most of my patients a blood thinner before they even go to the operating room, so the morning. And then if they're staying overnight, I keep them on it while they're in the hospital, and then make them get up and walk 3 times a day. Okay.
Is it typical that you have them stay overnight after surgery?
Most of my patients do stay overnight if we're doing if we're doing like a 3 parts, 3 body parts or 2 body parts, mostly for comfort, to make sure they're okay. Some want to go home, at the end of the day. It's their decision. There's, I'll sometimes recommend that they stay if we're doing a lot, but for a lot of them, if it's not covered by insurance, if we're not doing something that's covered by insurance, that overnight stay has to be covered by the patient. So at the end of the day, if they're comfortable going home, I'm okay sending them home.
Okay.
Wow.
All right.
Okay.
We use long-acting pain Oh, sorry.
Oh, no, go right ahead.
I was going to say we use long-acting pain medication. So kind of like a numbing agent you would get at the dentist. We use that in all the surgical sites, but this one lasts for 3 days.
Oh, wow.
So most patients who go home are comfortable. The people who typically stay are just a little anxious or nervous. And like I said, if their insurance is covering it, then great. And if not, I think our rate to spend the night is pretty reasonable. So some of them will choose to spend the night. They have 24-hour nursing care. Someone's bringing them their medications. But at the same time, someone's waking them up every few hours to check that they're alive. So it depends on where you find comfort.
Yes.
Yeah, I think I would stay the night.
Right?
Yeah.
I feel like I would just pay for the extra just to make sure that my pain level's good, and like that first night.
Yeah, just the first 24 hours.
Yeah.
I mean, I would literally probably stay. Oh, I was gonna say, like, I wouldn't mind staying even like for 3 days, to be honest with you.
She's like going bougie with it.
Yeah, I want like
I mean,
really
the hospital
chill.
charge is reasonable, but I don't think it's that reasonable.
Go to a spa, Mel.
Okay.
Go to a spa.
Fine.
Yeah, you might want to spend 1 night at the hospital and then 2 other nights at a 5-star hotel, and you might come out a little bit ahead still.
Yeah, I like that idea. I like where your head's at.
There's some nice Disney resorts down the street that might charge you a little bit less than the hospital. So
a little bit less.
I'm always down for Disney.
Oh my god.
Always down.
So kind of back to a little bit of like things that are in your system to make you not. So you said nicotine, no, but like how long does it even take for nicotine to get out of your system?
Generally, so studies have shown that it's you want to have someone quit smoking at least 4 weeks before surgery.
4 weeks. Okay.
Depending on the test, usually it's a urine test that we send patients for, and probably most offices are doing the same when we test for nicotine. Depending on the lab, it's probably going to detect it for up to 2 to 4 weeks, depending on the specific test that they're using. So,
okay. Yeah, I know that
I usually tell patients.
I did the urine test for my office before surgery. They test all of their patients before because they want everybody to be smoke free. So,
I didn't know that.
Yep.
Yeah.
Oh, okay. Yeah, my Dr. Patterson, I don't remember getting tested.
Hers was 6 years ago,
It was 6 years
it's
ago.
a little fuzzy.
Yeah, I mean,
I think as far as I know, most bariatric surgeons also do tests, probably because, again, when you're stapling, if you're stapling the stomach, that line can break down if you don't have good blood supply. So I know the guys at our hospital do test, because a lot of my patients tell me they quit smoking back when they had their bariatric surgery.
That's funny.
Yeah.
Yeah, no, I'm sure Dr. Patterson had me pee. I'm sure she did.
I'm sure she did.
Yeah.
I mean, just to be on the safe side.
Yeah. I mean, I'm trying to remember that day exactly. It just was kind of a blur until I was on the table. And then like,
well, I got tested like before they would even submit to insurance.
oh, I got tested then. I'm talking about like right before surgery.
Yeah, no, they don't test. Like, it was
They
like
don't
before.
test you then. It's
Yeah.
Gotcha. Okay.
Yeah.
No, I got the
I
initial
think
test.
that test actually takes a few days to come back.
Yeah.
Oh,
I believe it was a few days because they were like, okay, you're good. And I was like, all right.
Yeah.
Oh
So we do test. We do test everyone. Our patients get tested at what's called their pre-anesthesia appointment. Which all patients that are on to have to have. And so the anesthesia team goes over their medical history and makes sure everything's okay. They'll do an EKG if needed, chest X-ray, and then they'll get labs that they feel are warranted, and then anything that the surgeon has ordered. And so we get a nicotine test on every patient as well.
Oh, wow.
But what I was referring to earlier are the people who tell me in clinic when I meet them for a consultation, if they admit to smoking, those are the ones that I give a slip to, and then they don't get even scheduled until they send us a negative nicotine test.
Yeah, because you never know.
Well, I mean, it's just happened so many times that we put them on the schedule, they show up to PAT and it's positive, and now we're canceling them a week before surgery, and we're scrambling to put someone else on. So we found this to be a much more efficient way.
Yeah,
Plus, it gives
would
people
agree.
a reason to quit.
Yeah.
I mean, if I were, I would, because like you're wasting so many people's time. Like if they like put it all together and then now they can't, like that would suck.
Yeah.
That would just suck.
Yeah.
So what's the number one requested surgery, plastic surgery for post weight loss surgery patients?
I would say by far the abdomen. And that might be because it's, for most of our patients, we can typically get insurance to approve the skin removal on the abdomen. And I think for most patients, it's like you kind of think of like putting pants on, and that's, one of the first things you do in the morning. And when your pants don't fit quite right and you've got this like flap of skin on your abdomen, it's just not pleasant. So, the arms are probably number two.
Okay.
And I don't know if it would be number one if payment weren't a factor. I suspect arms might be number one for most patients. I don't know how you guys feel.
Well, and I think it depends on what, like the weight you were at before and how you carried your weight. Because I know like my arms were big, and I have a little bit, but not enough to like warrant getting surgery on them. Like my concern would be my abdomen. So
yeah, I don't care about my arms.
Yeah,
enough to do that.
Yeah,
no.
So
well, and it makes me
abdomen.
Okay. Yeah, it would just be abdomen for me.
Speaking of insurance, I want to know. Like, I know a lot of our listeners are wondering, how do you go about that?
Yeah, they all want to know.
Yeah.
Yes. So the number one question. So let me preface this by saying we have been seeing in some insurances what's called an exclusion. And so the analogy I always make is, a lot of like home insurance policies exclude flooding.
Yeah.
And so there are health insurances out there that are now excluding things like breast reductions and peniculectomies, which is the skin removal from the abdomen. It's few and far between, luckily, but we're seeing it a little bit more.
Okay.
So if you do have coverage, and again, the medical term is a peniculectomy, which is removal of the skin on the abdomen below the belly button.
Okay.
The requirements are from insurance that you are, for most of them, again, this might change depending on the exact policy, but the vast majority are going to be 18 months after weight loss surgery.
Okay.
Stable weight, I think most are 6 months. Some might be 3.
Okay.
So stable weight for 6 months. You have to have rashes below the skin fold. And then you have to try a topical or oral medication for 3 months for that rash. And it has to have failed to resolve. Prescription medication.
Okay.
Yeah.
I feel like that would cover a lot of people.
I think it would too.
It's going to cover, the majority of people. Correct.
Yeah.
Okay. Huh.
Yeah.
I'm just thinking about it. Like,
well, the only thing that doesn't annoy me, I totally get it. But I remember back in the day, like when I was like 2-3 years out, I would just get these little tiny red bumps, but it wouldn't be like on like a like an area, like a crevice, I guess.
A crevice, a fold.
A fold. It would just be on my skin where like my pant line would be. And it would be there for like a few weeks and then it'd go away. And I remember even my doctor was like, does that seem like a problem to you? And I was like, does it look like a problem to you? I'm like, I have no idea. Like, I'm not a doctor here.
Oh, it's a problem.
I'm like,
you're saying yes.
It's a problem.
But I still get it every once in a while, but it's just like one to two like big round ones and then they go away.
Huh.
So I just thought it was like sweat.
It just rubs in the wrong way.
Yeah.
I guess.
Yeah, probably what it is. It's an area. It could be one of two things. It could be a hair follicle if it was in the hair bearing area that was just clogged, or it could be a rash from when you have skin on skin, and then you get that like moisture buildup. It can just be kind of a reaction to that friction.
Gotcha.
I actually had that happen when I was. Before I had weight loss surgery, I was at my top weight, and I had it under my breast.
Oh yeah.
And because I have 3 autoimmune diseases, and so there were some days where I couldn't get out of bed. And so I'm just like hanging out in bed. And there was one time where it just like, it had rubbed just the right way. And it got infected. Like it was bad. It was real bad. And so I had to go into the doctor, and they cleaned it really well. And they're like, basically just keep it as dry as you can. And I still have a scar from it underneath. It was, I mean, it was a good, like, it was probably that big.
Yeah.
So it was about an inch.
Well, because I know what you're talking about with the rubbing and the rash there. I've just never gotten it to that point.
She is like crazy with her baby powder. So like I would be shocked if she had any type of rash anytime.
I know.
Well, so it's funny, because I get patients who come in and tell me, well, I don't get a rash, but I shower 3 times a day. And I'm like, well, if you didn't shower, let me help you here. If you didn't shower 3 times a day, what would happen? So some patients you kind of have to like lead on to get them to say what you want to say. Because if I write patient doesn't get a rash, then we're not going to help them get insurance coverage.
Right.
That's funny because we were just talking about this because my boyfriend, he had weight loss surgery. He had the bypass done 2 years ago, and he showers 3 times a day.
He does.
And I'm like, and it's so funny because he's like, don't make fun of me or don't judge. And I'm like, I'm not judging. It's just it just seems like overkill to me.
You're like, you don't need
and
it.
he's all, it's fat man syndrome. Like I have to be clean at all times. And I'm just like, all right, cool. I mean, I'm not saying that like I don't like you smelling good. I'm just, it's a little odd to me.
Yeah, don't judge. Just don't tell your plastic surgeon that when they ask you if you get rashes.
I'll let him know. Because eventually he does want to have plastic surgery. So it's kind of funny that you said that. So.
Well, yeah, because like I didn't know what to do. And like typically I just did my normal, like I noticed when it was only happening during workouts. So when I was sweating, when I was moving. And if I just was like being gross that day and just didn't like change, like I just hung out in that.
I mean,
all
we
day
all
long.
do it. We all do it.
That's all I'm in here. Like, don't you shave me. I hear people right now messing with me. Don't act like you've never sat in your own filth for over a day. People, we have all done it.
I've done it. There's some days where I'm like, nope, I'm not doing anything. I worked out and that's all you're getting from me.
Yeah. And I did it. And only time I've ever, when that happens, yes, I'll get like the little dots. Yeah.
Okay.
But it doesn't hurt.
But it makes sense.
But they do go, like, they'll come and go. Yeah.
Interesting.
And the last thing, there was one fifth thing. It's usually on physical exam. I mean, most patients can probably tell for themselves, but the skin has to hang to the pubic bone.
Okay.
Pubic bone. Okay.
Yeah. So some patients, some patients have noticed, like when they have C-sections, if the scar is really high, that can actually hurt them because sometimes that causes kind of like a ledge, and then the skin will just hang below that ledge rather than kind of flop down. But yeah, I would say the vast majority of patients meet those 5 criteria.
Okay. Good to know.
Yeah.
So we get very upset when we get denials because it's not an exclusion on a policy, essentially. So
gotcha.
You're just like, really? Like they've worked so hard to get to this point. You can't just like, okay, here's your reward.
Right.
Exactly. Yeah, I know.
I love it.
I wish they would pay for all these things, but maybe someday.
Someday, hopefully. Yeah, it's like we're taking our whole life, our health into our own hands. We're taking control of it. We're doing all these things, and like
Yeah.
They still like to just stick it to you sometimes.
Throw us a bone. Yeah.
Yeah, exactly. So I know, like, for me, I'd like to get the tummy tuck kind of done. When it comes to the belly button,
yes.
When is it necessary to, I guess, reposition
it?
Yeah. Like
reposition it? Okay.
Yeah, or like reform it. Is that a term? I don't know how to describe it.
Have you ever had to reform one, I guess, too? Yeah.
For the most part, so 99% of the procedures I do, I'm repositioning it.
Okay.
It's not included with the paniculectomy, but I think it looks funny to not do it. So we just do it, on those 99% of patients.
Okay.
So the way I explain it to patients is if you are like really still overweight, like we're talking BMI 40 plus, and you have this hanging apron, down to like your mid thigh or your mid knees, and it's blocking your ability to walk and get around. I do what's called an apronectomy, which is really just kind of wedging that area out and closing. And for those patients, I'm not taking away the belly button, but I'm not repositioning it either, because I'm just kind of cutting off that apron.
Okay.
And that's, like I said, very rare. It's someone whose BMI is still high, even after weight loss surgery. And they just need this for quality of life. For my other 99% of patients who are, BMI 35, not ideal, we try to get them under 32, but they're like, hey, I just want this done. We will do what's called a paniculectomy again. And that's, we wedge everything out but we cut off the skin, just very similar to a tummy tuck. And then I dissect upwards, I reposition the belly button, and then we close. So the scar is very similar to a tummy tuck scar. Essentially, the only difference between that and a tummy tuck is that we're not tightening the muscles. And with a tummy tuck, we would take off a little bit more skin because we are going all the way up to the breastbone in a tummy tuck.
Oh, okay. I see the difference in the names now. Like, it makes more sense in my head. I don't know why it didn't, but now it makes more sense of like tummy tuck and then the
paniculectomy.
That's going to take a while for me to be able to say.
Many people call it a panty. So
panty. I like it.
I like that. Yeah, panty.
And then, sorry, one other part of that, the panty. So you take out the bottom apron section, and then you pull up on like the pubic area, and then and you kind of just bring everything together, or
yes.
Okay.
Yeah, so it's a low scar. So in most patients, it's going to be hidden in your underwear, bikini line. And then typically we're cutting the skin up to the belly button, sometimes a little bit above. So all that skin goes away. And then we are dissecting the skin a little bit under the skin, on top of the abdominal wall. And then we pull it down. And usually we sit patients up. So, you're like this when you start, and then we're going to flex your body so that we can pull as much of that skin down and get as much of it off as possible.
Okay.
And then we reposition the belly button and close.
Okay. So if you have like a fupa, which I do, and so that's one of my concerns, is that something that can be fixed with a panty? Or okay.
Yeah, so for most patients, there's it's a pubic lift. You'll find some surgeons say that I guess it's all marketing, right? They say they do a pubic lift at the same time. I mean, it's kind of done at the same time. It's not something you do additionally. Yeah.
Okay.
Got it.
All right. That was my main question. So I wanted to make sure that was all like in one thing.
You're hilarious.
Yeah, that's all done together.
Can you kind of describe to me, like, just in general for plastic surgery, what are we doing with the fat? Where's it going? How many layers do you have to go down to even move this stuff around? Because I mean, I don't know the layering, because I thought it would go skin, like the 7 layer maybe of skins, and then fat.
Yeah, give us an anatomy lesson.
You're getting like a microscopic level. I think there's only 5 layers of like skin cells, if I remember correctly, from anatomy.
There's 5.
Biology. So it's skin. It's skin, and then there's a layer of fat, and then there's a few layers in between of what's called fascia. And those are usually strength layers. Those are the layers you want to suture as a surgeon, because if you try to put fat to fat, the suture will just kind of cut through it like butter. And so there's 2 of those fascial layers with, so it's skin, fat, fascia, fascia fat. And then there's the main fascia, which will usually be above the abdominal wall, or in the extremities, it'll be around the muscle. And that's your really kind of strong, very, very strong layer. And we usually don't go past that deep fascia layer. When we're talking about
how
body.
far are you going down?
So that's how far
so
he goes down.
The deep fascia.
The deep fascia. So you're going through muscle and stuff.
Yes.
You're going through the whole.
No. The fascia that's above muscle, that's as deep as we go, is that fascia that's
right
sitting above
it.
muscle.
Yes. Okay. Yeah.
Right
Okay.
Yeah.
Awesome.
All right.
I was nervous. Like, how does this work?
Yeah. And then tell us about, do you do liposuction? Is that part of it? How does liposuction come into it?
I would say for the vast majority of patients we do, I wouldn't say it's for every patient. It just depends on the anatomy. If there's certain areas, some patients come in and their arms are totally deflated. They don't need any lipo. So, we don't do any lipo. Some patients come in and they still have a little bit of fat back here that needs to be lipoed. Typically for my arms and thighs, I do some lipo just for contouring. Same with abdomens. But then you have to consider, again, if someone's just doing something through insurances typically don't cover liposuction. So, but we have pricing for patients who want to add lipo. If you want to do the paniculectomy and add the muscle tightening, we have all those charges. I kind of started all that when I came here.
That's fantastic.
So that we could offer patients everything.
Yeah, kind of like a
so you can kind of
breakdown
menu.
Yes.
Yeah.
A la carte.
I
mean, it's nice to know that you have those options, is that you can go in and say, well, yeah, I'd like to have lipo here. Or no, I don't really care if I have lipo, or, and kind of build your own obviously you would direct them in what you think would be needed, but it's nice to know that you have options.
Well, we have this question about the fat transferring. Do you do that for like breast enhancements, or I guess move it wherever they need to go?
My PA tells me I do too much fat transfer. So I do fat transfer at least 3-4 times a week for all kinds of different things. So we do fat transfer. It's pretty rare in weight loss patients that we use implants for breast enhancement. And there's a few different reasons for that. So one, most of my patients are younger, and so implants aren't made to last forever. And so if you put an implant in, I always tell a patient, you are guaranteed to have at least one more surgery, and likely several more than one. So that's the number one reason. Number two, most weight loss patients, like we talked about earlier, the skin is not the best quality, and it's not just the skin, it's all those structures we just talked about. So the fat's a bit weaker, those fascial systems are a bit weaker. And so when you put an implant, that's actually, I don't know if you guys have ever held a breast implant before, but they're not light. Yeah. They're not light. If we were in person, I'd toss you one so you could feel it, but they're not light.
Well, that might need to happen then. We might need to just be in person.
So.
Yeah. And so, you put the implant up here, and I've seen them over time, they start to migrate. And then before you know it, it's like down by your by the abdomen. And it's because the tissues just aren't strong enough to support that weight anymore. And so that implant just slowly kind of pulls through and stretches through those tissues and on its way down.
Interesting.
Because we had sorry.
No, go ahead.
We just know a fellow member of the community where they had like the double boob thing was happening, right? It was like a slip.
Yeah, it would like go up. And she would have to like push it down. And then Des, I know hers started coming out the bottom, like you're kind of describing. So that's interesting that, and that's the type of thing where you want to contact a surgeon that works with weight loss surgery bodies.
Yes.
Because then those things are less likely.
What I was going to add is that third point, it takes me back to the training we were talking about. So Dr. Rubin, who I trained with, developed this special breast lift technique where we just use the patient's tissue and we do what's called an auto augmentation. So it's an augmentation using your own tissue. And so basically using it's kind of spare part surgery. So what you women have is what we're going to use to reshape the breast and give you a nice lift. And it's going to look like you have implants, but we don't need to use any implants. And if you want a little bit more after that, then we do fat transfer.
Wow. Mel just got really excited.
That's what I'd like to do, sir.
Sign us up.
Yeah.
That's interesting.
Yeah.
So you could actually take the fat from like our abdomens and transfer it into as a breast lift type.
Correct.
Wow.
That is interesting.
With lots of cutting, but yes. In addition to the cuts that we'd have to make for the breast lift.
Yeah.
Yes.
Wish that it was like snap your fingers and it's done, but it's a lot of work.
It's a lot of work, but it's very rewarding. And I think, the patients are very happy. And especially, like I said, when you're dealing with a younger patient, I always tell them I would highly advise against putting implants in if you're in your 30s and 40s, because you are guaranteeing more surgery in your future. And as you said, the implants can stay up. That's called capsular contracture, where the implant goes high as your body forms scar tissue around it. And then what happens is your breast tissue will naturally, with gravity, it's going to fall over. And so that's one deformity you can get. I think that's what you said the people you knew were having. Yeah. And the other one is where the implant goes down and your breast tissue stays up. And, neither of those are going to get fixed without another operation. So,
yeah, I think both of our people that we're talking about, one of them's going to have another one, I think.
Have another what?
Surgery to fix it.
Surgery.
Oh, she's all done.
Oh, did she get it done already?
Yeah, she's all good to go.
Oh, okay. Yeah. So she had another surgery, and I know that Des had another one.
Yeah.
To fix her. So, So that makes a lot of sense. I would prefer to do a non-implant.
Yeah. I didn't know if it was possible.
Yeah.
Yeah. I know Kelly and I have talked a lot about the nipple area.
Yes.
How is the nipple addressed during these surgeries?
The lifts, because we've heard that like they have to like cut it around it and reposition it, and sometimes it cannot, like it you could lose feeling in your nipple, like.
So we do cut around it. Okay. Typically we make an incision around the areola, and for most patients we're going to shrink the areola at the same time.
Okay.
It's always a risk, yes, that it can be numb afterwards. Typically what I tell patients in a consult is after a breast reduction or breast lift, whatever we're talking about, you're going to go to one extreme. It's either going to be extra sensitive, which people don't like, or numb. And for most patients, you're going to come back somewhere. It may not be exactly where you were before, but somewhere in this more normal range. Okay. In my experience, hypersensitivity always gets better. The numbness can be permanent. So that's what I tell patients. It's hard to tell who's going to end up on this side and not get better. For the most part with breast lifts, the numbness does get better. It's usually more breast reductions where there's a higher risk of long-term numbness, because you're cutting out a lot more tissue in a breast reduction than you are in a breast lift.
Oh, okay.
Good to know.
You said that you make the areola smaller. How does that work?
Well, they cut around it.
You cut around it. Yeah.
Okay. I was like making sure I understood.
You're such a nerd.
Well, because you said that you make it smaller I thought you said you make it smaller before you cut. So I was like, wait a minute.
After.
How do you make it smaller before you cut?
As you cut. Yeah. When you cut. When you cut. Yeah.
Okay.
As you cut.
Because I was like, wait, so are we like putting an ice cube on this thing, making it smaller?
Oh my God. You're such
actually, if this might be TMI, but we actually have things called cookie cutters.
Okay.
I guess probably because they look like the things that you might use in baking to make perfectly round circles.
Okay.
And we have little washers that are different sizes. So, they start at like 35 millimeters, which is a little more than 2 inches, and they go up to like 50, which is almost about 2 inches. So you kind of pick and choose that size, and you push down on the skin, and it makes a nice little imprint, and then you'll just cut on that imprint.
Oh, that's cool. Huh. Wait, so we can pick our nipple size?
So we can pick our nipple size, yes. Your areola size.
I guess you could. Most surgeons probably like 1 or 2 sizes. Like I'm usually between a 40 and a 42.
Okay.
Sometimes a 38, 2 inches is a pretty big areola. I don't think I've ever used that size.
I don't think I want that.
And I think Yeah. And so, usually I'm using around a 40 to 42 millimeter. I think most surgeons do the same. So
interesting. I did not know that existed. And second, there is no such thing as TMI on this podcast.
Not at all.
Just so you know.
No, we want to know all the things.
We want to know all the things.
Yes.
No matter what.
Okay.
Yes.
Yeah.
We like to know everything. So that's why we ask about the nipple.
Yep. I had to know.
Well, because we know, I have my massage therapist. She got plastic surgery done, actually in Florida. But she didn't have weight loss surgery. She had kind of more of an extreme weight loss. She lost about 100 pounds and then had surgery. And so she's the only one that I've ever known, like not on Instagram, that had plastic surgery. So I'm like, I want to know everything. I have no idea what I'm getting myself into. And I know I'm like 95% sure that I want to have it done. This is making me feel a lot better though.
I'm all in now. I want to do it.
She's all in. I'm
good.
I'm creeping. I'm on the downhill slide of agreeing. So,
I mean, only thing that makes,
like I said, it's
sorry.
Yeah, sorry, go ahead.
I was the only that makes me a little nervous is knowing that like I'll be kind of like a Stitch doll. I guess is kind of the thing.
Yeah, but that's fine.
Yeah.
You look good in your clothes.
And that's all I care about.
Yeah.
Yeah, I don't care about scars actually at all. Like scars do not bother me.
Yeah, they don't bug me.
Like I don't care where it's at. It's like who cares? Like that's just a story and experience. I don't care where it's at.
Yeah. So
well, that's very important because there is a lot of scarring. But they fade. I mean, patients who are I guess the first thing you have to be accepting of scars, because if you're not and you think plastic surgeons are magicians who can wave a wand and do scarless surgery, then this is not for you. But scars fade. Typically at a year, those scars are barely noticeable, and the longer out you are from surgery, the less noticeable they become. So
awesome.
Yeah, it's good you're not afraid of scars.
No. We have plenty,
right?
Plenty of those wonderful stretch marks. So no.
Well, and I've gone through I have titanium from knee down. So I have scars from that surgery. So I'm just I don't care.
Yeah.
No. I have 5 screws in my ankle, 2 screws in my knee. You can see all the little spots. And those are the spots that are numb, which are interesting. If you just rub your finger across those spots, I can't feel. Is where the surgical little dots things are.
So can we talk about sodium?
Sodium.
I don't know how much I can tell you.
So
we can talk about it.
So after surgery, I've heard that you want to be very careful of your sodium intake because you can swell.
We've heard this several times.
Yeah. So do you have an amount that you, or is that not something that you really?
That's never come up. I think the big thing is, so yes, you can swell after surgery. I think the things that are going to help you swell or minimize swelling are increasing protein. So as you increase protein, you push fluid back into your blood vessels, or pull them into the blood vessels, and then you pee them out rather than having the fluid go out of the blood vessels into the tissues. So protein is very important for that reason. It's also important for wound healing. So we always recommend that our patients get at least 100 grams of protein a day for 4 weeks before and 4 weeks after surgery.
Damn,
that's a lot of protein.
You need to bump it up from you need to bump it up from your normal diet. I know typically after weight loss, it's 60 to 80 grams for, say a 70 kilo person. But when your body's trying to heal, you want to multiply that by 1.25 to 1.5.
Wow.
So I just usually tell patients 100 grams is an easy number to remember.
Yeah, no, that is.
That's super cool to know.
And with drains, so after, do you use drains? Typically,
I use drains, not everywhere, but for most body parts, yes. So the abdomen, if I'm doing a real tummy tuck, I have tried to get away from drains. So I do drainless tummy tucks. So there's some extra sutures we put in there to close that space. In weight loss patients, that doesn't work so well for everyone. So it just depends. On the abdomen, it's kind of a possible, depending on the patient type thing. For the thighs, depending on the technique that I'm using, there's one technique where I don't use drains, another technique where I do use drains, and the scars are very different for each. So that just depends it doesn't depend on the patient. It just depends on which technique I'm using.
Oh, okay.
Arms I've started to get away from drains. Breasts typically have drains, and then upper back, no drains, lower back, almost always drains. Although I'm starting to try to get away from that too. So
they're just kind of cumbersome.
Yes.
Okay.
That's the biggest. After the first week, when patients are still just not comfortable and not really getting out of the house. But after that first week, when they're more comfortable and they're starting to leave the house, that's the biggest complaint we hear until the drains are out is, when can I get these out? Or, God, these are so annoying. Or so we know, I'm aware.
For the listeners that don't know, why are there drains?
So drains are there to pick up any fluid that, like we were saying with the protein earlier, anytime you create a space, right? So once we've gone in and we've made an incision and we've cut out some skin and then we close it over, well, that space that we dissected underneath has become kind of a potential space. And the body doesn't like that. And the body wants to fill that space with something. And typically that something is fluid. And so the drains are there to empty that fluid, because otherwise your body can absorb a certain amount per day. Obviously, like we were saying earlier, there's fluid in the vessels and that can leak out. And so your body can deal with some of it. But, when you're talking about 100 cc's, 200 cc's a day, it can't keep up with that. And so what's going to happen is it's either going to kind of come out through the incision, or you want to put a drain in to get it out until it gets down to a level where your body can now deal with the amount of fluid that's left.
Oh, wow.
That's so interesting.
Yeah, I had no idea. Oh my God.
It's I knew that it was to drain, obviously drains, but you don't really think of all of the reasoning behind it and the science and our bodies are just so interesting to me to know all of these different things that it does for all of these little
tiny reasons.
Yeah. And procedures that you have done. Yeah. So weird. Okay. I love it.
And so to go back to the swelling, which is a fluid issue, it's going to be protein and compression. Compression is the other important thing to help basically close that space from the outside. So you're pushing those two layers down so that fluid doesn't accumulate.
Okay. How long are you with drains if you put them in?
I was going to ask that.
I'd say on average 2 weeks, maybe a little bit more, 2 to 3 weeks.
Okay.
It's rare. If it starts to get past that, we like to, there's a few different things we can do, like put some medication inside the drain, basically in the space to help your body close off that space.
Okay.
Because, like we were saying earlier, they get very uncomfortable and we don't want patients hanging out there with drains for 5-6 weeks. So there's a few different things we can do. Yeah.
Oh, okay. Interesting. And then sorry.
Oh, you're fine.
How long do you wear a compression garment?
Yep. That's where I was going. So
that's how in sync we are.
Yep.
We don't even have to.
I knew that was your next question.
The three of us are in sync. Yes. I love it.
Typically, we recommend at least 6 weeks. And then, so I think people have either a love or a hate relationship with their compression. So there's people who at 6 weeks are like, I'm done, I'm never wearing this again. And others who come in and tell me at their 3-month or 6-month appointment that they're still in their compression because they like the way it feels. So, but we usually say 6 weeks. That's typically where most of your swelling is going to be gone.
Okay.
The one thing I tell patients is if at 2 weeks you're feeling really good and you go for a 5-mile walk, you're going to swell, it's still you're early in your recovery. So you might notice some more swelling. So you just have to kind of be careful. And same at 3 months, you might go to the gym at 3 months and do something a little bit more than what you did the week before. Because at 3 months, at 6 weeks, you're cleared to do all activities if you don't have any wounds.
Okay.
So you might do something at 3 months and now you notice, oh, my belly is really swollen. I always tell patients you might want to use that compression again as you're starting to do more and more activities.
Okay.
For those days where you might do something more and feel that you're a little more swollen.
Okay. Yeah.
So with the compression, how do you put that thing on with all the drains? How does that work?
Excellent question. So for the most part, we in the operating room will put some kind of compression garment on for patients. Okay. So for arms and thighs, we typically like patients to buy their garments ahead of time and bring it with them to the operating room. So we're putting it on right away. As soon as you wake up and you're in your compression. For the abdomen, we use what's called a binder. You may have had one after weight loss surgery. It kind of just is like a sheet, this high. And it's like this big thing that goes around your belly and Velcros on the front. No,
nope. Neither of us had it.
Okay.
No.
Sometimes they use it after like hernia repairs or abdominal surgery.
Okay.
So we use that because we bring out the drains to the pubic area, and then it's really hard to put on compression with the drains there.
Yeah.
Or you can always, the other compression we recommend buying is the one that has a hole in the crotch area so you can still go to the bathroom. So if you have one of those, then you can just slip the drains through those holes and you can get into your compression. So
that's what I would go for.
There we go.
Yeah. I would not want to have to undo everything to pee. Nope. No, thank you. Not dealing with that.
That sounds awful.
That sounds like
you would be surprised
living hell.
You would be surprised how many people still buy that type, even though we absolutely do not recommend it. So
people, listen to your plastic surgeon, please.
Seriously, if they literally say we highly don't recommend this, why would you even look at it?
Even if it's $10 cheaper, just spend the extra, people. Spend the extra.
Save the cans. Yeah. I recycle like a mother.
Save the cans.
I can get $10 in like 3 bags.
Cans for my panty.
That's right.
I don't think they do that in Florida.
Oh, well.
In Oregon, they definitely do.
Sorry, it's 10 cents a can over here.
She takes all of mine.
Wow, that's more than, I think it's like 5 everywhere else, isn't it?
Yeah, it just got passed 2 years ago for the 10 cents.
Good for you guys.
Yeah.
They should make it, I remember when we vacationed in Hawaii a few years ago, it was insanely expensive to buy water. I mean, it was like a case, I can't remember, like $10 for a case. It was something insane. But then expensive. When you took the bottles back, you got a decent amount of money back. And I think that was like their incentive was to give you money back when you exchanged it. Yeah.
Yep. I buy my LaCroix because I'm still hopelessly addicted to my LaCroix. And so she gets all of my cans because I refuse to take them back. I won't. I just know I won't. Like my boyfriend gives me makes fun of me all the time. Funny. He's like, it's so easy. You just drop a bag off. And I'm like, but I will never do it.
No.
I will never.
We used to recycle, but we don't. I mean,
no.
And we recycle here, but you can't take cans back to the store like you do in other states.
Gotcha.
Okay.
Yeah, and you're at my house anyway, so
yeah, I just bring my bag of cans. Here you go.
You haul your bag of cans over to Mel's, and
and then I'm like, pretty much. Hey, on Saturday I'm taking all the cans back. And
yep. I'm like, hey, I need another bag for cans.
Yep.
We sound so weird.
I know, but it's fine.
Okay, so we did have a few questions from our listener or our followers on Insta. A couple of them did have some pretty good ones.
They did. And I think we might have covered a lot of them because there's a lot of like similar questions. So let's see from the group.
And I think once everybody hears this episode, they're going to have more questions for you.
More questions?
Yeah, just so be prepared.
There could be a round 2.
We may ask
you. We can always do a round 2.
Yeah. Awesome.
Sweet.
Awesome.
Yeah. So, I mean, you kind of touched on this a little bit, but recovery time. Will they need help at home and for how long? Because they live alone? So.
It depends. I mean, if you're having one body part done, you might be okay. We always recommend having someone at least for the first day or 2. Okay. Everyone recovers differently. I'm sure even with like weight loss surgery, you might have all had different experiences. So I think it's a good idea to have someone with you at least the first day or 2.
Okay.
And then for the most part, I think most people are okay being on their own. I mean, you might want to meal prep if you know you're going to be alone and no one's going to be around to get meals for you or cook meals for you. I mean, on the other hand, you don't really want to be ordering out for, 3 meals a day while you're recovering for 6 weeks. So, meal prepping, bringing things down, when we do breast and arm surgery, we don't like patients to lift the elbow above the shoulder. So you don't want to be reaching up high in cabinets. So I want to bring those things down. So there's a few things you can do if you are going to be alone for an extended period of time. But no, and then, while the most common complication is getting wounds, typically they're very small and they require like a one-time dressing change once a day or once every few days.
Okay.
And so that would be the most extensive thing you would have to do. And then the only other thing, if you have drains, is just to empty them and record them on a piece of paper. So there's nothing too crazy about it. But for the first day or two, you may not be up to getting up and getting around and getting your own meal. So you might want to have someone with you at home.
Okay. What would be a sign where they would need help? Like, is it
sign where they would need help?
Yeah, I mean, is there like redness on the area? Is there like a certain look or something? Or is there, I know fever, of course, call your doctor if you have a fever, but.
Right. So the things that you would need help for, I guess maybe what you're asking is like, when would you call your doctor? Because nothing really at home, you're going to need someone. Yeah. So fevers, certainly. And although it's not atypical to have after surgery, especially the bigger the surgery is, to have a low grade fever, that's very normal. Okay. But a fever that doesn't respond to Tylenol, or a fever that stays above 101 is definitely cause for concern. Redness, feet chills, nausea, vomiting that doesn't go away. Then the most common things we typically get are, like I said, small wounds. The other things we get called a lot about are, intolerances to pain medication, a rash to something. Sometimes patients get a rash to the skin glue that we put on. I've had patients who were allergic to the suture that we used. These are all rare, but they can happen. Like I said, what we get calls for, but nothing I would say that you really need help at home.
I just had a
flashback. The big things, the scary things that you might want to call 911 for are like chest pain, shortness of breath, pain in your calf. We talked about blood clots earlier. Those are the scary things, and you probably want to call 911 at that point, and not, having someone at home is not really going to help you for that.
Okay. So. I just had a flash to like vomiting after having plastic surgery, like having a panty. I was just like, oh my God, that sounds so bad. So
I mean, you just saying that made my vagina perk up a little bit. I was like, whoa.
You're like, no, let's not do that.
Ow, owie. Okay, so.
Yeah, for the most part, patients are totally fine. I mean, and infections are rare because we're not using any implants. So the risk of infection is really, really low. And if there is an infection, it usually responds to oral antibiotics. You're not having to be admitted back in the hospital. I mean, I can't remember the last time I had to take someone back to the operating room. It's been about a year now, I would say.
Okay.
A year, if not more, for like an infection or like a wound that was so bad after body contouring that I had to take her back to the operating room and cut away some tissue.
Okay.
So it's extremely rare, once a year, if even.
Okay. Good to know. So this one is, of course, about cost. They want to know, like, what are the averages that they should be looking at? And they listed arms, thighs, tummy tuck, and boobs.
But it also depends on the area that you're in, right? The area of the United States. I said that real weird, but
you said it correctly.
So very true. So in Beverly Hills, people might be charging $20,000 just for a tummy tuck, whereas $20,000 here is probably going to get you like 4 or 5 body parts.
Okay.
Yeah, so it just depends. I mean, again, a paniculectomy is going to, if it's covered by insurance, then it just depends on what your deductible is, what your co-insurance is. If you want to add the muscle tightening to that, I think it's going to be a few thousand. So that's gotten you to a tummy tuck. So it's whatever you owe insurance plus a few thousand to the hospital to get that done. I think a straight abdominoplasty. So if you say, I want everything, I'm just going to pay for it out of pocket. At our hospital, I believe is around 8,000. Okay. Don't quote me on these numbers.
Yeah, no.
So let's say 8 to 10.
These are generalized people.
Let's say 8 to 10. Yeah. But again, in Beverly Hills, you might be looking at 15, 20,000. And then some surgeons who, like our tummy tuck experts, might say, well, I take, it's crazy. I was talking to one of my colleagues and she knows I don't know if he's famous, but she knows a facial plastic surgeon in New York. So probably across the country, facelift is on average, maybe 10 to 15,000. She said he charges 40,000 for a facelift. And I was like, I could do one of those a month and make more than what I make now.
Insane. That's insane.
Yeah. That is a brand new car right there.
So I know a lot.
Exactly. So
a lot of our listeners definitely want at least a tummy tuck in the boob. So what is kind of like a range on that?
So like I said, tummy tucks probably 8 to 10. Boobs are probably also in the vicinity of 6 to 8. Typically for us, when you add things, it makes them cheaper. So it's not like, let's say 10 and 8, it's not 18. It might be 10 and 6.
Okay.
So the hospital has kind of some cost savings the more you do. And they've allowed us to discount some of our surgeon fees the more you do. So it's actually helpful to do more rather than less at the same time.
How many will you comfortably do at one time? Yeah. Body parts.
I do tell patients 3 body parts, depending on the body, for the most part. Yeah.
Okay.
So, the most often combination I'll do, depending on, some patients come in and they say, I want everything, and let's just do it the way you want, or, we kind of come up with a plan.
Yeah.
And so, sometimes we'll say, well, let's treat the upper body in one surgery and the lower body in another. And so if you're doing pretty much everything, we're talking upper body would be breasts, arms, and then upper back. So it's kind of like a bra line lift. If you can imagine where that bra strap goes in the back, you have a scar on the breasts that go under and then all the way around. Wow. And then the arm lift, of course. So that's one surgery. And then the second surgery would be abdomen, buttock or lower back, and thighs.
Oh, wow.
And that would be one of the surgery.
Okay.
Yeah. Wow.
That's
sometimes you get
that's
patients,
a lot.
Yeah. And at the end of the day, I always tell my patients, you have to prioritize what you want. So I don't tell patients you have to do A and B. I tell them, you tell me what bothers you the most, and then we go from there. So, the other common one I do is like a lower body. So abdomen and butt, and then arms together. And then we go back and do breasts, upper back, and thighs together. And then there's 100 other combinations we can do depending on what, each patient wants.
Yeah. Okay.
Wow. All right. I think that covers the general on that.
Okay.
Let's see.
Yeah, sorry, that was a long answer to it.
No, that's good.
No, we would prefer you to be more information, because we're all kind of like just trying to figure out where to go next. I know I'm 2 years out from my surgery, and I'm still trying to figure out okay,
what you're going to do.
Yeah. Cause like you said, it's a big decision, and you can't reverse it. So you kind of have to be completely on board with your decision, whether you're going to have plastic surgery or not.
So,
yeah, you can't reverse it. I would say luckily, I've never had a patient who said they did it and regretted it.
Okay.
I have had a lot of patients who said, I wish I'd done it sooner.
Okay.
On the other hand, and then, it is a big decision. Of course, it's not always free. It's not always covered by insurance, and not everything is covered by insurance. So I get a lot of patients who come in and tell me, kind of like maybe you guys, I'm on the fence, and their reasoning is, well, my husband doesn't want me to do this. He thinks, or my parents think I'm being vain. And so what I tell my patients is, think about, if this makes you happy, at the end of the day, it's your money and you spend it how you want. I have people who buy boats. Are they vain? No, they like fishing, or they like being out on the boat, and that's how they want to spend their money. People spend money to get season tickets for their sports team. So at the end of the day, if it's your money and this is something that's going to make you happy, and it's not like a sports, going to a sporting event that's like one night or a few nights. This is going to change your life for the rest of your life. So
yeah. No, that's very
well. I love that example though, because they are these are big ticket items that people do purchase, and why do we need to be shamed for doing something with our body? It's ridiculous.
No, I think there's no shame in it at all. So
yeah, no, I like that.
So there's a question about pregnancy. If you know that you're going to probably have another one, should you just wait?
I get that question every once in a while. So my answer is, at the end of the day, it's up to you. I think if you know you're going to get pregnant in the next year or two, you're probably better off waiting. Again, it is an investment of your time, your money, potentially, your recovery, time off from work. So I think if you know you're going to, I mean, so if someone's like, well, I'm planning on getting pregnant in the next 6 months, I would say, why are you going to have a pointless discussion. If you're not sure, I have a lot of patients who say, well, I'm not sure, I'm 30. We talked about not having kids. I say, at the end of the day, it's your decision, but I think it's fine to do it and then decide, if you're not sure, then 5 years from now, you might say, you know what, I don't want to have kids. So, you live with your nice body for 5 extra years. So.
But physically, even if you had plastic surgery, you can still have kids. Like it would
Correct.
still be
It
fine.
does not affect your ability to have kids. Yeah.
Okay.
No. Well, and also with say they have the surgery and they do get pregnant within 6 months to a year. How is that affecting their abdominal wall?
In my experience, and it doesn't, like I said, it doesn't happen a lot where we do a tummy tuck and then people have kids. So it's a very limited experience and I don't think there's any good data on it. But in my personal experience, I would say the abdominal wall doesn't stretch as much when you've tightened it. Now, if you do a paniculectomy, it probably doesn't make a whole lot of a difference, except that you might have loose skin again. And chances are your insurance company is not going to cover that second surgery. So I would say if your resources are limited and you're like, well, I can only do what insurance is going to cover, and you are thinking about getting pregnant, I would hold off because you don't want to have them cover it the first time, get pregnant, and then not get it covered the second time.
Yeah. Perfect. And then how long would it be for someone to go back to work? What is the average time frame? If they're just doing your 2 to 3 thingies.
Thingies.
I mean, luckily with COVID, people are working from home so much now. I usually tell them if you're just working from home and you can pop open your laptop, you can go back in like a week or two. And most people have been doing that. So, but if we're talking about more traditional jobs, usually 2 to 3 weeks. Like I just operated on one of our nurse practitioners. And I think she took 3 weeks off. And she had a thigh lift, which is probably one of the most difficult recoveries.
Wow.
That's usually like 3 weeks minimum is what I tell patients.
Oh, wow.
So, if you have a traditional job, I'd say if you're doing kind of multiple things, you want to take 3 weeks off.
3 weeks off.
Okay.
Awesome.
And that's if you're not doing any heavy lifting or strenuous activity at work.
Okay.
Yeah.
And
this is an interesting question.
Okay.
Yeah.
Is it dangerous to have a surgery last 6 or more hours?
So there's one study, I think it was from University of Texas, Southwestern, that showed a slightly higher risk of complications if surgeries lasted more than 6 hours. And so I think a lot of surgeons cite that study. And they might say, well, my cutoff is 6 hours. So I'm guessing that's where that question's coming from.
Okay.
In my experience, no. I've done 8-9 hour surgeries, 10-hour surgeries. I think, again, so we always have to balance patient safety and how much we can do in one surgery. Right. So in a 50-year-old who's had 3 heart attacks, probably not a good idea.
Yeah. No.
So I have a patient, for example, who he lost like 400 pounds, I think. He started at 700, maybe more, almost 500, I think, as a matter of fact.
Damn.
But he had a history of a PE, which is when that clot in your calf can go to your lungs. So those can be fatal. So it's not a joke. Yeah. And he had a history of that. So and he wanted everything. He wanted, the arms, the upper back, chest, abdomen, lower back, thighs.
Wow.
And I said, okay, we can do that, but we're going to do it in 6 surgeries. Because it was safer for him to do, one body part in a shorter amount of time, and get him off the operating room table, than to keep him asleep for 6 hours every time, or 7 or 8 or however long it was going to take.
That makes complete sense.
Yeah. But in a 30-year-old person who their only medical history was they were overweight and maybe they were diabetic and hypertensive and whatnot, but now they're, off blood pressure meds, off their insulin. They don't really have any medical problems. I think, 9-10 hours is okay. So I think you just have to kind of look at every patient individually.
All right.
I will say the more, and I don't think this has So I think the reason that study showed a higher risk of complications, and this is purely my theory, is it's not so much the length of time under surgery. It's actually that you can imagine if you're doing a 7-8 hour surgery, you're adding a lot of scars, right? You're cutting more out, something that's 6 hours versus something that's 2 or 3. And again, something that's 9 is going to be more than something that's 6. So I think that study, it found a higher risk of small wounds or wound complications. And I think it's more of a result. What I've seen in my practice is when I'm doing like a 9-hour surgery, I'm cutting a lot of skin off and I'm closing a lot of length of incision.
Okay.
And I think that's what it is if you don't keep your protein up, to get that wound healing, then you have a higher chance of getting wounds. So I think it's more of a result of the length of the incisions and how much your body is trying to heal, and not so much that the surgery took X amount of hours. I could be wrong, but that's my theory.
No, I
like it.
I think that's a good theory because it makes sense.
Yeah.
And you want to produce, so it's also the aftercare too of the patient, whether they're following the rules, they're following what you're recommending, getting all their protein. So,
right.
Okay.
Yeah. I think we pretty much hit on all the things.
Yay.
There might be one or two that we didn't, but we can definitely
we will
do
keep
more.
Track. Yeah.
Because
I think this is way beneficial. You are a very good explainer of our.
Well, thanks. That's good.
Sometimes we have some like random questions or thoughts, and so you did very well.
Thank you for dealing with our goofiness.
Well,
I've got a future in TV.
There you go.
Yes, definitely
Media.
in the podcast world.
You got it.
Well, thank you so much
I just
for
need
being.
now I need a cool studio like you guys and not just a window.
There you go. You just need a couple posters. You'll be fine.
Good to go. Good to go.
Some guitars, Awesome. Well, thank you so much for being on. We really appreciate you taking the time out to come talk with us and kind of inform us more of what you do and what our options are.
Seriously, you've definitely eased my mind a lot.
Yes.
Good. I'm glad to hear.
For sure.
I hope that other people feel the same way. It's been great. This was so much fun.
Yay. Thank you. And we will talk to you very, very soon.
Yes.
Sounds good.
All right. Thank you guys for listening, tuning in. This was an amazing episode.
Oh my goodness.
I'm mind blown.
So much information.
Yes.
It's insane.
Yes.
Like I almost want to like re-listen to it and just like take down some notes.
Oh, definitely. We will have to do that. Definitely. We will definitely have our form on our website that you guys can go on. You can ask questions. And if you have any questions after this, please let us know because we would love to have a part 2.
Oh, 100%.
So,
100%. And if you want to watch this, when it first drops, you need to go to patreon.com/OSLP, become our patrons. One, you support us. So like we get new software, we get new lighting, things like that to help out the pod.
Support your favorite girls.
That's right. And then you can also get to see these if you do the $10 or higher a month.
Yes.
Yeah.
And that we also have a support group.
Yes, we
do. So it is called the Winner's Bench because we are no longer losers. So we are going to get rid of that old loser's bench saying, and we are now the Winner's Bench. We fondly call each other the Benchies.
That's
and
right.
we have a chat that we all chat together. And you can ask questions about the surgery, before, after. It doesn't even have to do with surgery.
No.
We're just there for you to support you through your journey.
Yeah,
So,
like even recently we got to see where people were going for some shows.
yes.
And then we had some people that had some bad days and they were just telling us, they're like, thank you for just letting me vent and I have a place to go. And I was like, this is exactly what we wanted it to be.
Exactly.
So we have over 30 people. So if you want to join, just join us. It's a lot of fun. We're in it all day long.
Yep.
So.
And don't forget to check out our website. It is oursleeplifepodcast.com, and you can get all your merch. You can find episodes. All that fun stuff is right there.
Yeah. And don't forget YouTube. Ring the bell.
Yep. Subscribe and ring the bell. All right. Thank you guys for tuning in again, and we will see you next time.
Bye.